Respected chairpersons, thank you for my invitation. And first of all, let me pass my thanks and gratitude to Dr. Bansi. He's a wonderful, a very dynamic person as a president of SDI, and Dr. Sanjay. So, that's okay. So this is what I'm talking about: ACD and COVID-19 pandemic. So it has really badly affected our country, the whole global presence. It is Savai Mansingh Medical College Hospital. There's a 6,000 bed hospital. Proud to be a student and postgraduate from this institute. I did in January 1981. My MD. Here's the statue is Dr. J.P. Sethi. Sorry. Here's a Dr. J.P. Sethi, my teacher, my mentor, examining child, is known to be a pulmonologist state of Rajasthan, the biggest allergologist in history. My flow of deliberation would be, what is ACD and COVID-19? A stands for asthma, C for chronic pulmonary diseases, D for diabetes, and C for COVID-19 pandemic. We all know this is a virus, messenger RNA virus. Its size of 80 nanometer, microscopic, though it is not viable. It's not. It doesn't survive outside the body, but once it enters, it has done the global damages. What we have seen. What do you see? These are spikes, and the spikes which are like a corona-like structure, and that's the name given as a coronavirus. And the damage it has done to a mankind, global presence. 250 million people have affected, primarily the biggest country being United States, 47 million patients, with almost close to 8 lakh deaths. India being the second one to follow, 34 million patients, with 4 lakh 60,000 deaths. So very big damage has been done. So did it start 2003, coronavirus one first. At that time, the WHO secretary was Dr. Harleen. She was from Norway and she controlled corona first in a very good shape. But this time we had corona second. This lady is known as a Bat woman. She Zhang Li. In February 2020, Shi Zhang Li published an article in Nature titled "A Pneumonia-like Outbreak Associated with the New Coronavirus, Probably Bat in Origin." Still, it's a big problem. Where did it come from? Dr. Li Wenliang, who was the first to report an ophthalmologist at the age of 32, but died because of corona infection. It is a Dr. Zhong Nanshen who diagnosed this virus and labeled as a novel corona 2019, and he is the editor-in-chief, Journal of Thoracic Diseases from China itself. And on 11th February 2020, it was named as COVID-19 by Dr. Tedros, CO for corona, V for virus, D for disease in 19 because it was diagnosed. It came in December 2019. We all understand the transmissions. We all understand the symptoms. And the biggest is a loss of anosmia, loss of taste, coming the biggest way. And now these are the basic milestone of COVID-19. Now, the clinical picture of coronavirus, it has a triphasic clinical patterns. 80% patients just have a fever, temperature, little like a flu symptoms, and just recovers. But second phase, some of the people did enter into the second phase. The third phase, however, where the patient continued to be PCR positive, but symptom free. But some of the patients carry on as a long corona post-COVID syndrome. This is the biggest, very important slide, where we understand the asymptomatic phase or the mild illness. 80% patients remain in this stage. While some of the people, 15% enters a moderate illness, 5% goes into the severe illness where you become hypoxic, high respiratory rate and lung infiltrates are more than 50%. And few do succumb to the disease, the critical illness. The biggest point is isolation is important, and the viral replication, and the most important is hyperinflammatory syndrome. Now we recently, congratulate you, we have two drugs, oral therapy as a molnupiravir and Paxlovid has been approved by FDA, and molnupiravir has come to India with the sun. So what is an asthma? We understand what is an asthma. Asthma, we all understand as close mimic picture like COVID-19, and it is a long inflammatory disease of the airways, which is heterogeneous nature. It has a lot of endotypes and the phenotypes, where the patient has a variable recurring symptoms with reversible airflow obstruction and early triggered bronchospasm. Symptoms: wheeze, cough, chestitis, shortness of breath are the cardinal features. Generally worse at the night and has many varieties of endotypes and phenotypes. We all know that there's a narrowing the lumen because of bronchospasm with inflammatory cells and the swelling, and there's a lot of mucositis over there. With the pathophysiology, we all understand, and the classification is intermittent and persistent. And the patient has been always given asthma zone pictures, and the ACT is very important. In corona time, this is very important, significant. Patient has been given the charts, and according to that, they can report to their doctor whether they have a bad disease or not. The GINA guidelines has a beautiful illustration labeling of the labeling the asthma management. And this is a heterogeneous picture of the asthma, where we have an eosinophilic asthma and non-eosinophilic asthma. While eosinophilic asthma is better managed and does not have any serious problems with the COVID, while neutrophilic asthma or adult onset asthma has a terrible aspect with the asthma, COVID-19. Does asthma increase COVID-19 risk? Initially, whenever they started, everyone who was suffering from respiratory diseases like asthma and COPD, they were really scared. So they have in a medical records of 492,000 patients. On UK Biobank, the non-allergic asthma, what I call you as the neutrophilic asthma, significantly heightened the likelihood of severe COVID-19, while allergic asthma had not at all been proved. And in first stand comorbidities, asthma did never stand over there. So asthma does not stand as a first stand comorbidity. In WebMed.com, March 28, 2020, CDC combed through the case studies more than 122,000 Americans. It was in April 2nd, 2020. Severe COVID-19 higher if you have a diabetes, so not asthma. Relationship between underlying chronic lung diseases. With the chronic lung disease, are they increased risk with the COVID-19? Alteration in the local immune system, host microbiomes, excessive mucus production, and poor pulmonary reserve. But with the Science Daily on the 6th July 2000, again labeled as asthma does not seem to be increased the severity of the COVID-19. The Journal of Allergy and Clinical Immunology says the asthmatic people are never worse with the COVID-19 outcome. In Wuhan, 19 February 2020, Dr. Zhang, low prevalence allergic diseases, COPD in patients with smoking history indicated may not be the predisposing factor of COVID-19. Elder age and high number of comorbidities again bear the high risk of the COVID-19 outcomes. The receptor binding domain, the S protein, which binds to the receptor and has a big impact. Now coming to the COPD, we know that it is a third chronic disease in the world, having 384 million people are suffering from the COPD. 3 million people die every year from COPD, being third in the picture. And it is a treatable and preventable disease, COPD, but COPD always carries a bad outcome with COVID-19. This is a global presence COPD. And the chronic obstructive pulmonary disease is third leading cause. 80% deaths are in a low and middle income group. COPD causes persistent progressive respiratory symptoms, and the severity has been diagnosed as a CAT test. COPD assessment test, it is a total 25 marks and carries a 5 questions, and one can answer and can understand and realize the outcome. This is MMRC breathless scale, which is a modified medical research council, and this is a beautiful picture and assessment of the COPD. And the C and D classification of the COPD have a bad outcome with COVID-19. This is a COVID-19 and COPD, beautiful correlation. So COPD, who is unstable, gold guidelines C and D have a bad outcome. It is a systemic inflammatory state, high pro-inflammatory markers, and body decays over time. So chronic obstructive is always associated with a bad outcome because there is increased risk of morbidity and mortality. Because ACE2 receptors are high times, and the 5 times they increase severeness with COVID-19 in case a patient who is suffering from C and D, COPD. Asthma, COPD do not increase mortality, and now what we have seen the CD score, because once a patient discharged has to be regularly serially followed up monthly basis, because initially may not present as a bad lung, but later on the honeycombing is there, traction fibrosis are there, what you can see is septal thickening, making worse. But recently it has been come out that these are the people that are doing a little better, but 0.5 to 1% people still are worse with the disease even after 6 months of the sickness. So the assessment association of COPD and asthma in hospital mortality. Coming to the diabetes, COVID-19 and diabetes association. Diabetes is very prone, people are very prone for the bad outcome of COVID-19 because the virus itself damages the beta cells in the pancreas, and we understand the severity of disease, and we understand the India being the second to the China, going to be the capital of diabetes global presence, with a 65 million people are suffering from diabetes. Diabetes is a pro-inflammatory and pro-thrombotic state, and said to be the highest high levels of increased markers, level of markers, a pro-thrombotic state, what we can call as a hypercoagulability state, and it is a new onset of diabetes. The patient who so admits, and if a high fasting blood glucose levels, they have a bad outcome, and many of the patients who never been a diabetic in ever time or a hyperglycemia, once they had suffered COVID-19, they have become diabetics. So the chronic hyperglycemia should to be responsible for micro and macrovascular complications and have a 4 major biochemical processes: advanced glycation products, polyol pathways, hexamine activation of protein kinase, and the people who at the time of admission, the blood sugar levels have a direct correlation with the corona bad outcomes, and it is said to be the FBG at the time of admission is an independent marker of the COVID outcome. It is a dysregulated immune cell activity in diabetes been observed, and IDF.org organization, it is that diabetes is hard to treat in COVID-19, and fluctuations, variability, blood sugar levels are often seen. Dr. Shashank Joshi has done a good job. Yesterday he had presented on COVID-19 and diabetes. It was a beautiful lecture. Again, it was back in JAPI, May 2020. Diabetes is a condition with significant immune dysfunction, a condition of immune dysfunction. D and COVID-19, severe immune dysfunction leading to complications. COVID-19, D is a major comorbidity. Diabetes is a poor outcome, longer ICU stay, higher complications, poor prognosis, and they require a better triage. ACP now, 78% ICU patients, out of them 32% patients have diabetes, and 3 stages of Lancet. The comorbidity diabetes should probably to be the number 1, and with 22% or 16.2% patient of the total entry. A Ghoshan, diabetes and COVID-19, morbidity and mortality in diabetes cohorts with severe and critical stage. Glycemic variability had been the biggest problem in the management of diabetes in COVID-19. That's what I'm saying. A variable hyperglycemia plays a very big role because cytokine storm. And a greater increase in inflammatory and coagulation markers. Diabetes alone as a comorbidity had a greater risk for severe pneumonia as evidenced by higher mean CT score compared to the people who never had a diabetes. In SMS hospital, what had been the diabetes mellitus contributed 30% of the total admissions, and out of total the patients of COVID-19, diabetes mellitus had a 56% of the contribution. It's not coming here in the laptop. Excuse me, it's not being displayed. Yeah. AKI, area guidelines of allergen immunotherapy, has absolutely no contraindication in COVID-19. Dr. Esengor, President NCCP, has laid down the guidelines of allergen immunotherapy, and AKI, European Journal of Allergy, Asthma, Clinical Immunology, allergen immunotherapy should be continued. Allergen immunotherapy in COVID-19 can be continued in form of sublingual immunotherapy or subcutaneous immunotherapy. Ancient Netherlands, why the male had more problems with the COVID-19. ancient Netherlands in severe COVID-19, there have been genetic variants, and that the chromosome 83 makes a man's sex to be more susceptible. And the long COVID haulers post COVID-19, the post-corona after effects has been observed in 20% total ICU admissions, presenting a shortness of breath, myocarditis. Young deaths have been reported post-discharge with low ejection fraction because heart failure has been always associated, and arrhythmias have been reported. Myalgias, weakness, musculoskeletal issues, neurological symptoms, and they have been studied. The 468 patients have been observed in SARS 2003, and in Lancet 19, they have been observed, and still that patient, some of the patients are still having COVID fibrosis. Pandemic denial. Donald Trump never agreed with the COVID-19, and though the White House majority people did suffer, same with the Prime Minister of UK. To carry home message, diabetes stands number 2 as a comorbidity. Asthma has never been reported as a risk factors. Immunotherapy can be continued. Biologicals are today's medicine and does not make any difference with the COVID-19. Artificial intelligence is very important with electronic data. My data have been from American Academy of Allergy, Asthma, Immunology, where the David Lang is a editor, Asthma Allergic Foundation, AFA, Amen College of Allergy, Asthma and Immunology, and Indian Journal of Allergy, Asthma and Immunology. There was a picture in 2011, Contagion, where there was a story was of a spread of a virus transmitted by respiratory droplets and fomites. Loss of social distancing had resulted in a pandemic, and the vaccine did halt the process of the same almost same. So the UK becomes the first country to approve anti-COVID pill molnupiravir. India has come up, and the people should be given, such as the patient respiratory disease, they should be given my asthma plan where they can monitor their asthma, can report to the doctor at times when emergency comes. The vaccine has a proven value, and the game changer have been Moderna, Stefan Bancel, Dr. Krishnol's vaccine, Ugasahin, BioNTech from Germany, and Adar Poonawala from Covishield, Tedros, WHO Secretary, and Dr. Pfizer, this is Borla. And my sincere thanks to Dr. Fauci, who has stood to the time, and Dr. Balram Bhargav and CDC Director Dr. Ronald. We are proud of our Prime Minister, who has taken out this big country with such a big population, and 140 million people have come out and has raised, and the vaccination has done a good job. Say to our Health Minister also. So the Delta Plus, AY 4.2, can it make a difference? Can make a difference in case we will not observe the corona behavior. Europe seems to the epicenter of the pandemic. France has reported the 5th wave of pandemic. So dear friends, my all message that we should continue to behave with an adequate common behavior, because still we had not been seen, but there can be a third wave. So let's have good time, happy luck, and happy new year. Thank you very much.